Morning.
Morning.
I'm so happy to be here. I do want to introduce myself. My name is Marcia Griffith, and I'm going to be the moderator for today's talk and presentation here today. I do want to thank the Dana Alliance for Brain Initiatives and AARP Atlanta and the MetLife Foundation, whose generous support made this program possible. Also, I'd like to thank the Gainesville Civic Center for hosting us today. And with that now, we are going to begin by introducing the panelists for today's presentation. And before I do that, I do want to say that the format for today is that I am going to introduce the panelists, and they are going to talk amongst themselves about the topic for today's presentation. And at around 11 o'clock or so, we will stop and you'll have the opportunity to ask questions. So do keep that in mind and jot any questions you may have down as you listen to the presentation today. So we'll begin with my introduction of Dr. Patrick Griffith, who happens to be my husband, who is a neurologist, but if he would introduce himself and talk a little bit about your area of expertise, I would appreciate that.
Thank you. It's nice to get permission to speak from your wife. I was trained in neurology, and after that training, I served in the military as well as in academics. I've been fortunate to have been neurology faculty at Emory, at Morehouse School of Medicine, and at Meharry Medical School in Nashville, Tennessee.
And the other is Dr. Gaur, and I'd like you to introduce yourself, your affiliation, and then if you would begin the discussion as well.
Okay. I'm Swati Gaur. Some of you may know me. I am from here in Gainesville. I did my training in internal medicine in New York with Columbia University. I then did my fellowship in geriatrics in Pittsburgh for 2 years, and since then have been practicing geriatrics. And geriatrics is basically a study of older adults, and have completely, thoroughly enjoyed practicing geriatrics here. Currently, I am with Northeast Georgia Medical Center affiliated nursing homes. I also set up the palliative care program for the Northeast Georgia Medical Center a couple of years back. So here I am.
Okay. And if you begin today's discussion, you're going to, Dr. Griffith or you, talk about the normal brain and then proceed from there.
So I'm going to use a visual that was taught to me by one of the nurses when we did this kind of Staying Sharp program in Oakland, California. And this nurse was a nursing educator in geriatrics. In your bags, the ones who've gotten a bag, there's a little blue rubber model of the brain. So if you think of that model and my hand, and her analogy was that your thumbs are like the front part of your brain that goes to the nose, the back of the nose. Your fingers are the front part of the 4 lobes of the brain. So the front part is called frontal lobe. Your knuckles are the temporal lobe. So if you think of the temples right here, the most important function performed by the temporal lobes, deep in the temporal lobes, has to do with memory. And that's often the most concern for aging individuals, in that they worry that if they lose their memory, they could be having problems that would need the services of Dr. Gaur in geriatrics. And she's going to pick up on the problem of memory. Further back, meaning the dorsum of the back of my hand, is the parietal lobe, and that's the lobe in the brain that tells you where things are in space. The last part, which would be my wrist, is the back part of the brain that you actually interpret what you see. It's called the occipital lobe. So, the take home, there's a frontal lobe, a temporal lobe, a parietal lobe, and an occipital lobe. And if you think of my two hands, the brain is developed into two parts that are called hemispheres. So if this is a sphere, hemi means half. So there's a right and a left. The way that our brain works, most people talk with the left part of the brain. The frustration is that whereas language is in the left side of the brain, the strength is on the opposite side. So you talk with your left brain, but the controls for the strength in your body go to the right side.
Very good. And to add to that, like he talked about the frontal part, and this becomes relevant when we see patients with dementia, and why you must have noticed that why two different people with dementia might not exactly be the same way. There are some people who have, you know, your garden variety. I cannot remember my way back home, versus somebody who might have a lot of behavioral symptoms of dementia, a lot of agitation, and may lose what is the sense of what is appropriate. And some of that goes back to the normal brain functioning. For example, when we were talking about the frontal lobes, these lobes are responsible for the appropriateness. You know, I always tell when kids are growing up, when they're teenagers, their frontal lobes have not sprouted. I think we sprout around 30. That's just a joke. You know, they have it, they have it, but that sense of what is right, what is socially appropriate, is in that frontal part. And a lot of dementias are actually not Alzheimer's, and it's a good segue into the types of dementias that we see. But one kind is that frontal lobe dementias, which, you know, primarily comes out as behavioral problems and that loss of sense of appropriateness. And that is a very specific kind of dementia. Now, going to what dementias are, and do I have dementia if I, you know, lose my keys? I lose my keys every so often, and I hope I don't have dementia, you know? So what makes it for a dementia? Essentially, dementia is not just memory loss, but like he was saying, there are several parts of the brain, and depending on which part is affected more, not only the memory is affected, but also the functioning. We call it executive functioning. For example, you have to get food. What happens? What are the different steps that that you will have to take in the retrieval of food? So if you're going to cook, are you able to get all the ingredients, cook them, and essentially don't burn them, but put it on the table? So that is all the steps of executive functioning. If you get a bill, you know, getting a bill, making, you know, and having this trigger that I have to write a check, writing the right kind of check, balancing your checkbook, those are the different steps that, you know, are a part of executive functioning. So essentially, not just the memory is gone, but also different parts of your function might be gone, and it's called dementia when those deficits start affecting you to the point where your life, your day-to-day life has started getting affected. Now, there is 45%, you know, out of people with dementia, only 45% get told that they have dementia, or their family members get told, as opposed to 90% with cancer. And I think that is where the awareness comes in, that we need to know, you know, if there is memory loss. There are different kinds of dementia. Only 1/3 of people have Alzheimer's dementia. Another 1/3 would have stroke-related dementia, you know, like people who have cardiac conditions, they would have more stroke-related dementias, and the other third would have other different kinds of dementia. One of them I talked about, that is the frontal lobe dementia.
Good. So to make the different dementias applicable to what you may encounter in a family member, neighbor, church member, etc., you need to keep that division that Dr. Gaur just talked about. What most of my patients ask is, if so-and-so in my family has dementia, am I going to get it? And my question is, what kind of dementia did the doctors say you had? So it gets back to the split into three that Dr. Gaur just talked about. Is it Alzheimer's? And even in 2015, we're disappointed that we don't have a cure. There's a lot of research, there are a lot of what's called clinical trials, but basically, we have no cure for Alzheimer's disease, so it's called irreversible. What I challenge my students and the residents in training that I work with is that should make you look for a cure. And the reason is we are doing such a wonderful job of taking care of our parents and our neighbors, etc., that the fastest growing segment, I'll repeat, the fastest growing segment of the population are people living past age 85. That has never happened before. The problem is the people who live past age 85 stand a 1 in 2 chance of developing a dementia. And that's the frustration. You do all the things you can do to live a long life, but age puts you at risk. It also lets me tell you that not all dementia is passed on, meaning that it's genetic. Only about 1/4 of dementias, of Alzheimer's dementias, is genetic. And there are 2 kinds. Early onset, which means it comes on before age 60, and late onset, it comes on close to age 85. Okay? But it's only 1/4. My research interest and my concern is, what about the people who don't have a genetic cause, but they're having loss of cognitive abilities? So it's called sporadic or non-genetic. Well, the thing that happens in that big group is what we call vascular risk factors. And that's what Dr. Gaur is trying to say, that the vascular risk factors are, no surprise, high blood pressure, sugar diabetes, bad cholesterol, smoking, okay? All of that's not good, okay? So if your doctor says that you have any one of those 4, please make sure that you're taking your medicine. Please make sure that your diet is appropriate. So if you have high blood pressure, you shouldn't be taking things with too much salt. If you have sugar diabetes, you have to watch the amount of sugar content in your food. If you have cholesterol problems, yes, they may put you on a medication, it's called a statin, but you can do yourself a favor by baking your food rather than deep frying it, by eating more fish than fried chicken. And the compromise that I do is when I eat chicken, I take off the skin and discard it. But there are different strategies. So one of the things that has gotten a lot of press is something called the Mediterranean diet. And what they've found is that people in the Mediterranean area who eat lots of fish, cook with virgin olive oil, nuts, fresh fruits and vegetables, meaning never refrigerated. Okay? They grow it in their own garden. They don't put all kinds of preservatives on it before it gets to Publix or whichever food chain you get your vegetables from. And red wine on occasion. So there is a way, and lots of fish. And there even, the dietitians have taught me that some of the darker fish is better. So salmon, tuna, I'm blocking on the other names. But the point is that if you eat more fish, and they're talking maybe as much as 3 times a week, and stay away from, quote, red meat, you're doing your body a favor.
Yeah.
So I'm going to go back to Dr. Gaur and then come back to those 4 lobes that we talked about.
So essentially, in this whole discussion, there is a good news and a bad news. The bad news he's already given you. The good news is essentially whatever you're going to do for your heart, you will end up doing good to your brain, you know, to simplify everything. Hypertension and diabetes, they are called silent killers because they will never tell you that this is a problem till you end up in a bad shape. So very, very important to watch those, very important to watch your diet. You know, red meat is a high risk factor for coronary artery disease as well as brain. And the way I describe it to my patients and their families is it is essentially the same pipeline that is giving you blood into the heart, into the brain. So whatever affects the heart in a bad way will also affect the brain in a bad way. So that's why now the new classification is basically when we talk about strokes, it's also called a brain attack. And we treat it the same way that we treat a heart attack. So same way to think about it, same risk factors. Overweight, you know, obesity is a risk factor, eating red meat is a risk factor. Hypertension, diabetes, smoking is a big, big risk factor. I mean, smoking, you know, if at any point you cut down smoking, it is always beneficial for you. And
I think the segue from that is, and I'm sure you're thinking it if you're not verbalizing it, is what can I do to prevent it? Mm-hmm. So the point of staying sharp is you can delay how things go. You can stay sharp. And you're going to stay sharp in 4 ways. The first is to control those vascular risk factors that Dr. Gaur just itemized. High blood pressure, sugar diabetes, cholesterol, stop smoking, lose weight, eat properly. The second is physical activity, and we were led in a wonderful way by our exercise person here. Here's the good news. If you exercise your body, you're also exercising the memory part of your brain. And there are studies that the memory part of the brain gets bigger if you exercise your body. So increase your exercise. And it can be as simple as walking for 30 minutes to 35 minutes, 4 to 5 times a week. Okay? So exercise your body, exercise your brain. That's the first. The second is, how do you enhance the mental activity? So coming to programs like this, that's a plus. Being involved in your community, and I was blessed to talk with the villagers, and Augie is a gentle person, so he's not raising his hand, but they have an active educational program. So one of the things that you have to know, there is new evidence that you continue to learn. I repeat, you continue to learn as you age. They used to think that you only had a certain number of wires in the brain, and as you got older, you lost them. You can exercise your brain by being socially engaged in educational activities, which is primarily mental, but also it's important to feel that you're still active with people of your own age or your own interests. Okay? So, control the vascular risk factors, more physical activity, exercises, exercise your brain in terms of mental activity. And 4, social engagement. Go to church, go to synagogue, meditate. Dr. Gaur is going to talk to you about what she does in her own family life. But the point is that when you're doing that, you're not only relaxing, you're managing stress. Everybody has stress because there are choices that you have to make in a day. If you can minimize stress, you age better. You stay sharp longer. Dr. Gaur mentioned that a lot of the patients who come to her facility as a geriatrician, they say, well, you know, my family was never told that so-and-so has dementia. What we tell our students and our residents in training, ask the doctor before you pay your bill. That's a good time to make sure that he or she is going to answer you. You don't give them the money unless they answer you. You say, I came in because I'm having trouble with my memory. First question, do I have dementia? And hopefully that doctor will say, well, we did certain tests, etc., and you have memory problems. Second question, if I have dementia, what kind? Remember the 3 kinds that Dr. Gaur said. Is it Alzheimer's? Is it stroke-related? Or is it other? The biggest other that some people sort of don't pay attention to is the kind that comes on after head trauma. Who is having more dementia problems from head trauma in our society? The former football players and the former boxers. Okay? There's a debate as to whether or not soccer players get it because they had the ball, the repeated concussions. So there's a whole research that's going on for an entity called CTE, chronic traumatic encephalopathy. So getting your head hit is not such a good idea, particularly if it's a concussion that's enough to, quote, knock you out. Okay? So back to the questions for the doctor. Do I have dementia? If I have dementia, what kind? And the third is, what tests have you done? Because if I have dementia, I need to know, is it reversible or is it irreversible? So our students get a list, and it's got 4 Ds. Delirium, which is an acute change in how you perform, almost always related to either having a fever or some kind of problem with your electrolytes. Depression. Depression. Some people who are sad are inattentive to the questions that the doctor is asking. So they get to score lower, but it's their depression that's making them score low. The person with dementia often makes a guess and is wrong, so that person scores low. So they can look very similar. It's very tricky. It's even more tricky that a person can have both. So if you can afford it, we encourage patients to get psychological testing to make sure, are they performing at their educationally appropriate level? Did they go to high school? Did they go to college? How many degrees did they get, etc.? Okay? So delirium, depression, the medications. What medications does your doctor have you on for your medical problems? Sometimes it's the medicine. There's certain medicines that interfere with how the brain works. And then the last, so if the doctor has done all that, the last one is dementia. And the big question, and Dr. Gaur will take over, is the dementia reversible or irreversible? Alzheimer's is only one of the irreversible dementias, only one. It's the most common, but it's only one.
So as we worry about Alzheimer's dementia, I think that is the most popular dementia that we talk about. As physicians, we want to make sure that our patients don't have the kind of reversible dementias, because that's something that we can do something about. And some of those are, we'll test you for your thyroid function, because sometimes thyroid can, low thyroid levels can show up as dementia. Everything slows down. The brain slows down. So a lot of times we will give them thyroid medications and people kind of wake up. The brains wake up. The other thing that we look at is vitamin B12. Sometimes deficiency of something as simple as vitamin B12 can disguise itself as dementia, and a lot of times what we say is we can stop we can stop, but it's hard for us to reverse that damage that has already been done in the brain. So it's very, very important early on to test for B12 levels and make sure that we have enough of B12 levels. And that happens as we get older and a lot of stomach problems happen. And now that we are taking so many, we call PPIs, Pertonics, and all these other medications to make sure that our stomach is settled, the absorption of vitamin B12 is not the greatest. So we want to make sure that you don't have a B12 deficiency. That's the other reversible causes of dementia. One of the causes of dementia that does not get talked about very much, and Dr. Griffith touched on that, is medications. That is one of my, if you have ever heard me speak, I always talk about medications. I have had patients who have come in, who have dementia, who have delirium in the hospital, that he talked about, that sudden change in mental status, waxing and waning of mental status, and families are upset, patients are scared and upset, and they come in to our facility and we start changing their medications around. Medications that are longer acting. As we get older, we should be on lesser medications, not more, because our bodies are not able to metabolize medications that we were able to when we were 30. And we don't have that kind of buffer that we can absorb all the insults that the medications are giving. So something like as simple as Ativan or Ambien or diazepam can disguise itself as dementia, and people come to us and we taper it down very carefully. What I'm not suggesting is stop medications on your own, but definitely, like you said, before paying the bill, go to the doctor and negotiate. When you are being put on one more medication, go to the doctor and say, oh, here is this list of 10 or 12 medications that I'm taking. What can you take me off of to put this medication on? I think that is a place where we are going as geriatricians. We are realizing that our patients are on way too much medications that their kidneys and their bodies are not able to handle. So I think that's something very, very, very important. And we have seen changes in people when, again, they have woken up and they are more functional, they can get more enjoyment out of life. One of the things that I would like to touch upon is mindfulness. Sure. That you touched on. Mm-hmm. And being mindful, Harvard Medical School has, you can go on their website and they have this, they talk about mindfulness. And essentially what they show is that, being mindful, and they have a lot of actually, they will walk you. They have sessions that you could walk through the sessions on your computer. And essentially what it does is basically being aware, have the self-awareness, and keep the self-awareness without judgment. Let the thoughts come through, but be aware of yourself, be aware of the present without judgment. That is called mindfulness. What it has shown to do is decrease your stress. It actually lowers the high blood pressure. So it actually helps with a lot of physical things, but it helps memory. It actually, in healthy people, we are able to remember more things. So that is something that I would strongly encourage you to check out and be mindful. I meditate twice a day. I feel like, with the advent of iPhones and all these wonderful gadgets, I have become a bigger multitasker than I was, and I tend to lose more keys more often than not. And so do my kids. So we actually went to a meditation retreat where we practice mindfulness. I meditate twice a day. And I have found that I'm able to hold on to thoughts. When you try to hold on to the being in the present, even now, you will find that it's harder for us to do than it used to be, maybe 40 years back, when we did not have so many distractions. The other thing that you had talked about is how brain is plastic. We call it as plastic. It changes over time. And there have been studies, they studied bus drivers in England. They studied bus drivers versus taxi drivers. And what they found out is certain parts of the taxi drivers' brains were more developed. They were bigger. Just because bus drivers were keeping the same route over and over again. However, the taxi drivers had to actually find their routes, so their hippocampus was bigger. Same thing has been noted in medical students who have to study for their exams, and when they're studying for their exams versus people who did not have exams, their brains were different. Some areas were more developed than the kids who were not studying for this exam. So over the years, we have seen in different studies that people's brains change, and how they change is, the brain cells, they connect with each other through the synaptic connections, we call it. It's a very nice connection to each other, and these connections become bigger and they connect more, the connectivity increases. So that's something that we can do as we exercise our brains more and we exercise our bodies more, we do make those connections. When you talked about exercising 30 minutes, again,
a minimum.
At least 30 minutes. But walking can do it. When we think about exercise, we feel like, oh my goodness, I have to hit the gym. No, you don't. You can walk outside. Walk outside. This is a beautiful community, and absorb all the, when she was talking about smell the roses, go outside and enjoy this beautiful community. Exercise is not only going to help your brain, and they say that it increases the blood flow to the brain, and that's why your brain is healthier. It also will help your heart. It also decreases depression. So, with that one little 30-minute session, and nobody should be ever telling me that they don't have 30 minutes in the day to work, just go walk outside and be happy and exercise. You hit a lot of things. The stress levels go down. It gives you such immense, that little investment gives you such returns that there is no excuse for not exercising. The other thing is social engagement that, Dr. Griffith talked about. There was a recent study that I saw where, people were reading books. It's great to read books. However, what is better is those book clubs that we used to have that we are somewhat getting away from. Get back to those book clubs. So people who, it helped with memory, it helped with, mental functioning, when not just reading the book itself, but going and having a discussion about it. And one of the things that we talk about is, with that social interaction, you expand, and that plastic brain starts developing. The learning that Dr. Griffith talked about, it actually transforms into a growth of those synaptic connections when you are pushing the boundaries of what your understanding is. So coming to talks like this, going to talks like, talking about Middle East, or Brunel has, some talks. If you go there and expand your horizon about what your understanding is, it stimulates that synaptic connection and brain growth.
So one of the things that a lot of the pre-K kids do when they get home is their mom or dad says, what did you learn in school today? So what I want you to answer is that I learned about the 4 Ds, right? Depression, drugs, delirium, dementia. I learned about reversible and irreversible dementia. Dr. Gaur threw in a word, the hippocampus. The hippocampus is deep within the temporal lobe, and that's the most important structure to do with memory. The other thing you want to know about memory is there are two kinds. Basically, it's new memory, or what some people call recent memory, and then old memory. So, and this is meant to be humorous, okay? Because my wife is here. We don't understand why women outlive men. We don't understand. All right. So, one of the old memories that a lot of women have is of their first husband. Nobody thinks that's funny, so I'll move on. Recent memory is, what did you just have for breakfast? What did you just have as a snack that you came in? The people with the hippocampus that's not working properly cannot tell you what they just had. It doesn't stay. In the Staying Sharp booklet, they talk about something called memory and learning. Okay? So there's a kind of memory that you use, and we don't see any players in here except maybe for this young man. The players are the ones that get the digits. Isn't that what the young people say? They meet somebody of interest and you get their digits. I'm not, my player card was retired 46 years ago when I got married. So, but the players have to have the digits, and that's what you need to call that person back or to simply make a phone call. You can then, quote, discard it. You don't, your working memory, you don't go into long-term memory, okay? But you use it to perform a function. The other problem is that, particularly in Alzheimer's disease, the most important problem is the new memory. The new memory. So, standard of care. When I see a patient in consultation for possible Alzheimer's disease, because at the end of the day, that's what most people worry about. Do I have Alzheimer's? Okay? The good news is that if we're able to do the things that keep us staying sharp, we can delay the onset of dementia by 5 or more years. I'll repeat, we can delay the onset for 5 or more years. What's the payoff to delay it by staying sharp? The number of people who get dementia drops by a half. So there's a payoff for having an active physical lifestyle in terms of exercise. There's a payoff to stimulating your brain. And Dr. Gaur talked about mindfulness, but it could be playing bridge. I didn't say poker because that can be a problem depending on what the stakes are like. Any poker players in the group? But it's the activity, it's the sharing, it's the camaraderie that we want you to continue to use. It could be with your senior center, and again, my friend Augie, where they have weekly meetings, is that right? Or weekly educational sessions. You ought to, starting today, say, I'm going to be a lifelong learner. I'm going to be a lifelong learner because my brain is plastic enough that I can learn a new language, I can learn a new skill. The taxi driver analogy that Dr. Gaur gave, they say if you go to a certain place every day, test yourself by going with different routes, because each different route lets down a different memory trace and you're using a different part of your brain. Now, my family teases me. They say, why are you using your left hand so much? The answer is because most of the time If you're right hand dominant, you do everything with your right hand. That means you're only using the motor parts of your brain on the left. The left side, the right side of the brain, which is controlling the left hand and the left leg, is sitting there doing nothing in terms of motor. So make it work. It's just sitting there unused. Okay? So you've got to continue to do all of the things because I want to be a lifelong learner. I want to be a successful ager. One of my heroines is a lady that I was fortunate to work with at Meharry and in Nashville. And I'll tell you this story as quickly as I can. She decided she wanted to get a PhD in gerontology. And the best place that she could get it was in Germany. Okay? She had to learn German while she's doing all of the requirements, the course requirements, to get your PhD and write your thesis. Dr. Garrett is now a PhD in gerontology.
How old is she?
My wife asked me, how old is she?
Yeah, she was older when she
And
started.
all the men in the audience will understand you never ask a lady how old she is.
But she started her PhD at an older age.
Yes,
is
she
the point.
started her PhD when she was Medicare eligible.
Yeah, that's the point. That's the point.
But that's the thing. I am going to be, starting today, I'm going to be a lifelong learner. And I'm going to stay sharp by doing those 4 things. I'm going to increase my physical activity. I'm going to increase my mental activity. I'm going to increase my social engagement. And the 4th, I'm going to control the vascular risk factors. When I get to the doctor, I'm going to be my own advocate. Before I pay him or her, I want to know, what have you done to tell me what kind of problems I'm having, and is it reversible or irreversible? If it's reversible, did you look for the tests that Dr. Gaur talked about? So I will finish, because we're about to go to the
We have something else.
audience questions. Another take-home point is think of the word dementia. So if you wrote it in your book, if you have a pen, there's a pencil, but I don't think it's sharp enough. Think of dementia vertically. D is drugs. E is emotional, and you can write beside emotional, depression. The 2 consistently reversible conditions are depression and drugs. You just stop the drug. Okay? Now, M is metabolic. Things like thyroid. Then N for nutritional. Make sure that the person is eating properly, getting the vitamins in, that they're not dehydrated. So D, E, M, E. The second E, eyes and ears. Make sure your eyes have been checked. Make sure your ears are checked. If you're not hearing properly the tests that the nurse in the doctor's office is giving you, you're going to give the wrong answer because you didn't hear them properly. And they might give you a low score. Okay? So eyes and ears. D, E, M, E, N. T, trauma or tumor, meaning cancer, or a head blow. Then I, do you have an infection? A simple thing like, it's not simple, but a urinary tract infection or a respiratory infection can make your mental status change, and then you come in with not a dementia, but a delirium. And the doctor needs to look for an infection in the 3 commonest places: the blood, the urine, or the chest. Okay? So don't let them give you labels unless they can justify why they're using that label. And A is arteriosclerosis, atherosclerosis, any kind of autoimmune problems. But the thing is, just think of that list and try to see where you fit. So.
Right. All right, thank you, Dr. Griffith. Before we move on to the question and answer part, I would like to ask Dr. Gaur to talk a little bit about sleep and aging.
Oh, absolutely. One of the questions that I get a lot is, I don't sleep well anymore, right? And what can I take to make my sleep better? And the first thing, and what happens is, again, that there's a certain amount of sleep that is required for our brain to function appropriately, right? So that's one of the things. The second thing is, if you're not sleeping well, the first question I'm going to ask you is, what are you doing during the day, and what is your sleep? We call sleep hygiene, which is basically what we say is, the bed should be used for only 2 reasons. One is to sleep and the other to have sex. So those are the only 2 reasons why the person should be in bed.
It's not in that order.
What you should not do is lay in bed and try to watch TV. This is what we tell our folks. You should not lay in bed and read, because then your body gets used to that idea of, oh, this place is for, laying in bed, watching TV, and then you start having insomnia. The other thing is, try to get that physical activity in. A lot of people, when they come to me and say, well, I need a pill, I say, no, you need exercise. Let's go and do that 30-minute of walking. And the other thing that happens is that nightcap that you have a little too late, or the coffee that you had a little too late. Caffeine is going to last in your system for a lot longer than it used to.
Can you go to the microphone?
Too late. She's saying, what is too late?
Oh,
Yes.
okay.
As far as caffeine is concerned, coffee, I would say after 2 o'clock. So the question was, what is too late
It's after
for
11.
something like coffee? After 2 o'clock is, what we suggest is try not to have a coffee after 2 o'clock, because that caffeine is going to stay in your system and keep you awake. As far as alcohol, tea, it also, so what happens is, not only is it a stimulant, but it also makes you go pee at night, right? So those are the 2 things that happen. So, when we ask patients, we always say, well, what happens through the day? So I will get a good history, and I'll find out that a lot of people wake up because they have to go to the bathroom, right? When they have to go to the bathroom, then, alcohol will make you want to go to the bathroom if you have it, that when you're, yes, that nightcap. It's going to hurt you in more ways. So try to have your wine with dinner or a little bit earlier than dinner. That's what I would suggest. Try to limit the amount of water that you're drinking at night after dinner. Tea and coffee are both stimulants. They're going to keep you awake. They're going to, they're going to wake you up, as well as they're going to make you more likely to go to the bathroom. Wake up and go to the bathroom. One thing, in the interest of your brain function, please never do is don't take Tylenol PM for sleep. Never, ever take Tylenol PM for sleep. Let me repeat myself. Benadryl, which is the main ingredient for Tylenol PM, or any kind of Advil PM, do yourself a favor, don't take Benadryl unless you're having a bad allergic reaction to something. It's a medication that causes more harm than it does good if taken where it should not be taken. It's a very effective medication, but it has its role. And
Therefore,
sleep,
it's one of the drugs, remember?
Yes.
Drugs that you may need to stop.
Tylenol PM, Advil PM, and Benadryl. So anything that has Benadryl as an ingredient, there was this thought process that if we give a little bit of Benadryl at night, you're going to have a good sleep, but it does so much harm. It slows the whole brain down, and not a good medication to take for sleep.
Thank you so much. Well, we're ready now for questions and
If I
answers.
can be allowed allowed to add?
Oh, go ahead, I'm
Yeah,
sorry.
please.
Okay. Sometimes when you look at the ingredients on the back, it won't say Benadryl, it'll say diphenhydramine. It's the same thing.
Yeah.
And that's what people take when they're doing an international flight, when they're a little bit anxious, etc. One of the geriatricians in New York, upstate New York, that I work with says that is the commonest offending drug that in her practice in geriatrics, and she's a professor of geriatrics, Syracuse University, is to stop diphenhydramine. Okay.
Good words. Okay. So we're ready now for questions and answers. And if you would raise your hand, someone will bring you the mic. We ask you to ask one question, please.
And to keep it short.
And to keep it short.
Please comment on Prevacid. Is that the new fancy drug that they keep hustling everybody with that makes you have a brain working, helps your brain?
What was the name?
Predacil. Predacil?
Prevacid is for
Prevacid.
stomach.
Prevacid is, when
an
we were
antacid.
talking about
Yeah.
PPIs, which we call PPIs, which is kind of a technical term. However, it is for the acid, to control acid in your stomach.
That's not what I'm talking about. It's a thing that they claim will keep your memory going better. Prevagen. All right, Prevagen.
I am not aware
Yeah,
of.
the jellyfish business.
Okay. I'm not aware of that, and we just had an international Alzheimer meeting, and I don't remember seeing it come out as one of the conference discussions. So it tells you that what I do is I encourage my patients to bring me whatever it is they're on. So if he came to me as a patient and said, should I take Prevacid, I would look it up. I would look it up on Google, I would look it up on Moogle, I would look it up on Facebook or wherever, because I need to know what drug is it, what family, what are the side effects, has it been tested? If it's been tested, where has it been tested? And I'm rigorous about that. I don't stop patients from taking something, but make sure that I know what you're taking. And I'll give you two examples. One is aloe vera, and I'm not complaining about all of the people who have that as a home business, but it's not clear that that's been scientifically proven to be better than the sugar pill, which is called a placebo. The second is ginkgo. It took 6 years of your tax money to have NIH do a multi-center study with ginkgo. It does not do any better than placebo. So your doctor, what I was taught by Herb Karp, who was my chair, my first academic position at Emory, is the physician's responsibility is to make sure that what your patient is taking has been proven, because families are so desperate, they will, quote, try anything.
Right.
And your responsibility as a physician is who makes the drug? What kind is it? Who was it tested in? How long were they on it, etc. So I'd have a lot of questions before I say, I agree that you should take it. Now, I'm not stopping him from taking it, but I need to know about it, and is it interacting with any of his other medicines?
Right.
You know? And I forget what the statistic is, but the average patient who's a geriatric patient is on 10 or more medications. It's a lot.
Absolutely. And if you're on more than 9 medications, there is a 100% chance that one of your medications is interacting with your other medicine.
And not in a good way.
And
Another question?
so what I was saying is, if you're on 9 medications or more, there is a 100% chance that one medication is interacting with the other one. So be aware of that. As far as the medications for Alzheimer's dementia are concerned, most are the typical medications that we give, which, one of them I'm sure you're very familiar with is Aricept, the other is Namenda, Exelon, and other medications like that. As far as we know, there has not been a breakthrough which is a whole lot different from these traditional medications that are out there. So, and again, to Dr. Griffith's point, it's when we get older, our buffers decrease. So I am always very cognizant of the fact that I will not be using my patients as guinea pigs. So what happens is a new medicine comes out, and lately we have seen that despite the FDA approval, people might not react the right way to the medication, and then they are kind of pulled back, or there's a big warning that comes in. So what I hope to have is, as a physician, the medication be out there for at least a year or more, so that I get a chance to see the post-marketing of what happened with that medication, unless it's a breakthrough medication that is going to, the risk and benefit analysis compels me to use that medicine in a certain patient.
All right, I'd like to go on, if you don't mind,
I
see if there are any other questions.
While she's going to the next question, I would...
Raise your hand if you have another question.
I would
please.
like to endorse doing clinical trials.
Second lady.
I repeat, you should consider going to an Alzheimer's disease research center if you have been given the diagnosis of Alzheimer's disease. It may be that that center, and there are at least two in the state of Georgia, one with Georgia Health Sciences University, which used to be Medical College of Georgia, and then Emory. Okay? So at least go to them, take all of your medical records, and ask the question, I have been diagnosed with Alzheimer's disease. Is there a drug that's going to be tested that I can participate in, or my spouse can participate in, or my mother can, you know what I'm saying? Because somebody has got to test these medications.
Right, thank you.
During your talk, you said delay.
Yes.
Now, does that mean we're all going to have Alzheimer's?
Wonderful question. Wonderful question. There was an editorial several years ago, and it says, if we all live to be 100, are we all going to get Alzheimer's? The answer is no. That there are several centenarians, meaning they live to 100 or more, who have successfully aged, stayed sharp, and they're cognitively intact. Now, the group in New York says that they can tell the successfully aging individuals, and this is Dr. Galvin's group at NYU, the brain of that person, even if they're 80, looks like it's somebody in their 50s and 60s. So they can predict by imaging that you're going to be able to delay. And I would predict that they're doing those 4 staying sharp things that we talked about. The successfully aging person who is able to delay, not prevent, delay. But what's going to prevent it is continued research.
Very good, thank you.
And it will be delayed.
Oh, yes. Oh, yes.
You got-
Well, that's what we're
No.
working towards. That's what we're working towards.
Okay, next question.
I'd like to know if melatonin is safe to take to regulate your sleep.
I would say a lot of people do take melatonin, and we don't frown upon it like we frown upon Benadryl. The first step in having a good sleep is follow the sleep hygiene, which is basically keep yourself awake out of bed for X number of hours. Make sure that you exercise. Make sure that you're not taking a stimulant at the end of the day. Make sure that your congestive heart failure is in good control, and go to bed only when you're ready to go to sleep. If you cannot sleep, get out of bed, sit in a chair and read a boring book. Don't watch TV. Read a boring book. You would want to go back to sleep. Okay? After that, if you do want to take that sleep aid, melatonin as a sleep aid, you can.
As long as it's not too frequent.
Absolutely.
Where you become dependent on it.
Yes.
Okay, thank you.
How much does inheritance have to do with all of this?
Wonderful question. So you remember the breakdown of 3s that Dr. Gaur started off with. if you take the family of dementias, 1/3 is Alzheimer's, 1/3 is related to stroke, and 1/3 is other. We're finding in the Alzheimer group that of that 1/3, only 1/4 are genetic. And the two genetic types are early onset and late onset. Early onset, you get symptoms before age 60. Late onset, you get them before you're age 85. Okay? So, in the other group, one of the fastest developments of understanding the genetics is in the frontal type that Dr. Gaur talked about, the one that looks like CTE, that the presenting complaint by the family is the individual has lost their social graces. And I'll repeat. The individual with frontotemporal dementia, their personalities change. They do unusual things socially. So for instance, if you've had a lot of coffee like I had this morning, your bladder is ready to go, right? But the social grace says it's a room full of very nice people. I'm going to wait. The frontotemporal patient does not wait. They will use the plant at the end. They will just go in the first door because they think that it's the door to the restroom. They won't wait till it gets to the bowl. They just go. Okay? Frontotemporal. That's one of the ones where there's finding more and more genetic changes. They're called mutations. So Alzheimer's has these clear two types of genetic things, but it's only a part of it, and then frontotemporal.
The other thing that I would like to bring attention to is that, when we talk about vascular dementias, how the risk factors of high blood pressure and diabetes, there is some genetics involved there.
Mm-hmm.
So, for example, coronary artery disease, like it goes from, it runs in the families. These risk factors run in the family, and then you could have vascular type of dementia where there are small mini strokes in the brain, and now, there's dementia. So, we have to be aware of that. The good news in that is if you do have those risk factors, they are modifiable if you do the right things by, the hypertension and sugar diabetes, then you can delay and prevent some of that.
So this is a test question for the audience. How many people, raise your hand, have heard of the term stroke belt? Stroke belt. Stroke belt. B-E-L-T, belt. Okay, so the people who've raised their hands can tell their neighbors there are 11 states in the Southeast that have more stroke than anybody else. 11. Now, recently they found out that there's a stroke buckle. So belt and buckle. There are 3 states in the Southeast that have more stroke than the other 8 to make up the 11 in the belt. So, we'll start in the back. What do you think are those 3 states? Georgia, correct? Okay. Okay. North and South Carolina. So if you look at the geography, there are 3 contiguous states on the East Coast. All kinds of questions. Are we smelling the same air when you're doing your exercising? Are we drinking the same water? Are we eating food that's, there's something wrong with the soil in those trees? There are all kinds of questions.
Or are we frying our chicken too much?
I don't know. But that was the people that said Mississippi and Alabama and whatnot.
Okay, thank you.
I still have a question about
hold on.
sleep.
There's
still
one
have
over
a
there.
One in the back and one over here.
Speak up,
And one
dear.
over here.
Go ahead.
Speak up.
Okay. I still have a question about sleep.
Sleep, okay.
I'm taking temazepam, and I want to know if it's habit forming or what you recommend.
After Benadryl, right up there with the Benadryl, the medication that I would ask people to stay away from is temazepam. And it's also called Restoril. There is a reason for that. As we get older, our body composition changes. The water content in the body goes down, the fat content goes up. These medications are stored and distributed in the fat. What happens is that you take this medication in a younger adult, they would be able to get it out of their system within 24 hours. Temazepam is one of those longer acting medications. It will take somewhere between 3 to 5 days to get it out of your system. All right? So I would say if somebody has to have a sleep aid, and if absolutely needed, a shorter acting one is better. Generally, temazepam, anything with AM at the end, like Ativan, Restoril, these kind of Xanax, those are called sedative hypnotics, which basically can warp the way you think and also will cause you to have sleep. They can be habit forming. So, however, I have decreased gradually the doses of them, and you can use other alternate medicines that are not in this subcategory and still help patients sleep.
Is an option to use it only twice a week or something like that, if you absolutely have to?
I would say that that is a discussion between you and your physician. If you are typically on these sedative hypnotics, because there are some people as we get older, so somebody might be responding to temazepam or Ativan well when they are younger. We also call what is called paradoxical agitation, where people actually get more excited when you take a medication, and that's a testament to how our body changes. There are some other kind of non-habit forming medications that we can prescribe before I would use it as a last resort.
Okay.
Okay, we have time for maybe one more question, please.
Thank you so much. And would you talk more about the effects of increased vitamin B taken daily, like 5,000 units a day?
Okay.
Are you talking about vitamin B?
B.
Yes.
B as in boy?
B as in boy.
D as in David?
No, B as in boy.
B as in boy. Yeah.
I can start.
You can start.
Okay. So Dr. Gaur mentioned that Restoril gets into the fat, so it's called lipophilic. The B vitamins are among the group that are water soluble, so you never overshoot. If you take B and C in any amount, your body takes as much as it needs and the rest it pees out. But D, E, A, and K are fat soluble, so they're lipophilic. So there's a danger of taking too much D, E, A, and K. But B, you can take as much as your body needs.
Can you talk about Parkinson's in the brain?
Absolutely. So in that other category, remember we made it into threes? Parkinson's is in that other category. Parkinson's is like the opposite of Alzheimer's. If you have Alzheimer's for a long time, when you get it much later, 15, 20 years later, you start to slow down. Parkinson's is the opposite. You're motorically slowed down, and you could have tremor or you could have slowness in walking and moving. And you don't get any memory problems until you've had it for 20 or more years. There's a newly discovered form of Parkinson's that's called dementia with Lewy bodies. Dementia with Lewy bodies. The difference is they look like a Parkinson patient, But instead of waiting 20 years to have memory trouble, they get it within 2 years. 2 years. And so you have to know, do you have Parkinson's? Is it a kind that comes on because you're getting older, which is called idiopathic? It's just as you age. And you're losing the parts of the brainstem that end up causing Parkinson's. But it could be that that part of the brain is damaged because you had a stroke, because you had an infection, because you took a medication. Some of the stronger mental health medications cause, quote, Parkinson-like symptoms. It's called EPS. So the doctor needs to tell you what kind of Parkinson's you have, what stage are you in, because early on you may only have a tremor on one arm, but later on in stage 5 you may have to get help to get around. You may be in a wheelchair or something. That's one. Then the other is, do you have DLB? And the last is, do you have Parkinson's because you had head blows? Who's the famous person with Parkinson features and used to be a boxer? Okay. So I'm not saying he has it because his medical records are private, but I can tell you that the CTE that I'm describing is the newly recognized post-concussion syndrome, and it's being studied in Boston. There's a neuropathologist named Ann McKee who is the champion for it, and she's a Green Bay Packers fan.
Oh.
So she says she's there to save football, not to stop it, to save it.
All right, I'm sorry that we're going to have to bring this to conclusion afterwards, if you don't mind. But I would like our panelists to give us some last words of advice, final words of wisdom, if you would. Please, Doctor.
I would say one of the things that is a take-home should be a take-home for everyone is that 30 minutes of exercise is going to go a long way. Minimum 30 minutes, 5 times a week is going to go a long way, not only for brain health, but also for heart health, for depression, and just overall well-being. Number 2 thing is, when there is a question of memory loss, when there is something that is out of the ordinary, when your health starts failing, always go to your physician and ask them to look at the medications. One of the things when we talked about Parkinson is the use of medication, and I cannot tell you how many times patients are diagnosed as Parkinson's disease, and I find that it's reversible, and it was because of some of the medications that our patients were on. Crosswords, Sudoku, mental exercises like that, make it into your routine. And socialize, learn something new, go to a pottery class, start painting, come together as a community. I think those are the pearls that I would say I would give to you. The other thing is depression. A lot of people have depression. Their depression is negatively related to cardiac disease, to brain health. Make sure that if you feel that you're depressed, you're treated. Now we have new kinds of medications that are non-habit forming that can be taken off once that depression is treated. So always be aware in yourself, your loved one, your family members that that is treated.
So mine is very short, and that is, please do all of the things that Dr. Gaur just said. And I have a bag here, and it says the Dana Alliance for Brain Initiatives, which is the foundation out of New York that sponsored Dr. Gaur, myself, and my wife coming to you today in conjunction with AARP and in conjunction with MetLife. If you did not get a bag, please get a bag. The most important book in the bag is this one. It's called Staying Sharp, Successful Aging in the Brain. All of the things that Dr. Gaur and I tried to say in the 30 or so minutes that we talked are in this book. At the end of the book, it has resources. So it has phone numbers, email addresses, names of organizations that can help you. And at the top of the list is AARP. So if you can just stand and wave so that they know the role that's able to do. And then they have things like the National Institute of Aging, National Institute of Neurologic Diseases, so that you can know that there are lots of research going on, that the pressing health issue for our presidential candidates and for the health policy people is who is going to take care of the people that are successfully aging? What plans are you going to have? Concrete plans, not political promises. What specific concrete plans are you going to tell the American public about how to take care of the elderly? Where are they going to live? How long are they going to live? Okay? What are you going to do about it? Okay, specifically. What you can do for yourself is not only read the book, but it has a page, for instance, and it says what things you can do to live a healthy lifestyle. So page 20, towards the end, it has a checklist. The checklist is do's and don'ts. The do's and don'ts are exactly what Dr. Gaur just said, okay? Exercise, don't smoke, don't take too many medications, on and on. So please get a bag. Please read the contents. Please, as the ARP said, share this with your neighbors, friends, relatives, any group that you're in.
All right.
Group activity
And
is
with
good.
that, we really want to bring this to conclusion. I'm so sorry. But we do thank all of you for coming today, and we thank our panelists. Please give them a round of applause.